Hello everybody and welcome back to Emergency Medicine Quest. In this video we will be discussing about blood and its components under the hematology playlist. Make sure to like, share and subscribe to the channel for more such content. We will begin today's lecture by talking first about blood banking. One thing that every physician needs to know is to understand how long the blood products stay viable when they are stored appropriately. Normally, when the blood collection banks contain an anticoagulant, then the blood remains viable for 35 days, and addition of additional products can make the viability to a maximum of 42 days. Let us now also review the types of blood. So remember that blood typing is the process by which we determine what category the blood falls into based on what the antigen is expressed by the blood cells. There are two major types of blood groups that we normally discuss about. So we have the ABO blood group and then we have the RH groups. ABO blood groups, so just to recap, in blood group A contains antigen A and antibody B. In blood group B, it contains antigen B and antibody A. In AB, it contains both antigens but does not contain any antibody, and O does not contain any antigen but contains both groups of antibody. That is why, remember, it is easiest to give blood to AB and it is easiest for O to donate blood. The second most clinically important type of blood system is the RH. For example, if a person has A positive blood group, so this positive basically stands for the presence of the D antigen. This blood system is most relevant when there is a pregnant patient at hand because, for example, we have a patient, a mother who is RHD negative, and she gets exposed to RHD positive blood. So she will develop anti-RHD antibodies which can cross the placenta, go into the fetal circulation, and result in hemolytic disease of the newborn. And this is why we say that whenever there's a trauma case and the patient is a female, we don't know what her pregnancy status is, the best blood to give her is O minus. Meanwhile, male patients and postmenopausal women can definitely receive the O positive blood. Emergency medicine physicians need to familiarize themselves with the difference of type and screen and type and cross testing that is often done with blood products. When a type and screen is ordered, usually the patient's blood is sent for analysis and then they find out what the patient's AB group is, what the RH group is, what are the antigens that are present. So normally type and screen is done when a patient has a lower chance. There is a chance of the patient receiving blood, but it's lower when compared to type and cross, where we know more likely that this patient is about to receive blood. Type and cross is basically type and screen. So they first check the blood group of the patient, the RH group of the patient, check for other antigens, and also keep blood units at standby till an order is placed to them as to how many units must be dispatched for transfusion. Normally, type and screen takes about 5 to 10 minutes, so it's much lesser time, and type and cross match takes more time, about 30 to 40 minutes. Every emergency medicine physician needs to know what this 1:1:1 ratio stands for. When we are transfusing someone with blood, we normally in the ratio of 1:1:1. So remember the three P's: packed RBCs, plasma, and platelet, all in the ratio of 1:1:1. So if you give 1 unit of RBC, you have to give 1 unit of plasma and 1 unit of platelet. At what level do we transfuse patients? If the patient is a stable hemodynamically hospitalized patient, we normally transfuse them at 7 grams per deciliter of their hemoglobin. But if the patient is having pre-existing cardiovascular disease, if they are about to undergo orthopedic surgery or cardiac surgery, In those cases, we transfuse them if their hemoglobin is less than 8 grams per deciliter. Other than the RBCs that we infuse, there are also special preparations of RBC that we should know of. So, washed RBCs are basically red blood cells that are washed with saline, and it removes any plasma, it removes any protein. This is particularly helpful if the patient has got a history of an allergic transfusion reaction. If a patient receives multiple transfusions or is undergoing chemotherapy, then we use something called as leukocyte reduced packed RBCs. Basically, it filters out 99% of the leukocytes that are present. If a patient is pregnant or if a patient is organ or bone marrow transplant recipient who is CMV negative, in that patient we normally give them CMV negative packed RBCs. The patient is coming with blood that is directly donated by the family members. In these cases, we give them irradiated packed RBCs. Let's talk about fresh frozen plasma. So 1 unit of fresh frozen plasma basically contains 200 to 250 ml of volume. What is the indication of giving someone FFP? Normally it is done if a person is having a massive transfusion or massive hemorrhage. If we want to reverse a vitamin K antagonist like warfarin, and one interesting use of FFP is in ACE inhibitor induced angioedema. As for platelets, the decision to transfuse platelet is obviously very variable. In most adults, if their platelet count is less than 10,000 and they have a risk of spontaneous hemorrhage or develop spontaneous hemorrhage, then if the patient is about to undergo a central venous catheter placement and the platelet count is less than 20, if a patient is about to undergo a lumbar puncture and the platelet count is below 50,000, if a child has got ITP with signs of active bleeding, or if the platelet count is less than 10,000. Moving on to massive transfusion protocol. So, what defines an MTP is basically giving 10 units over 24 hours, or a more practical approach is if we give more than 3 units over 1 hour. Normally, when an MTP is called for, the products, as we discussed earlier, are given in the ratio of 1 is to 1 is to 1. Although there was a large multi-center randomized clinical trial that compared the use of 2 is to 1 is to 1 ratio of packed RBCs, FFPs, and platelets versus 1 is to 1 is to 1. And they found that there was no mortality at 24 hours or at 30 days. But most physicians just stick to 1 is to 1 is to 1 since there is enough evidence supporting it as well. Every emergency medicine physician needs to be well aware of the complications of massive transfusion. So, one of it is hypothermia. So, in that case, we can manage it preemptively by giving warm IV fluids, by using blood warmers and warming lights or blankets. These patients can also develop electrolyte disturbances like low magnesium, low calcium, or variable potassium levels, which can be again treated. We know when a patient undergoes massive hemorrhage, they develop acidosis, and often citrate that is present in the bank blood can worsen the acidosis. We will now talk about the last component of today's lecture, which is the complications of transfusion. We can divide it easily into two categories based on how quickly the reactions develop. So we can classify acute and we can classify it into delayed. The first category under acute is minor allergic reaction in presentation like urticaria, wheezing, angioedema. If a patient develops allergy-like symptoms, in these cases, we generally stop the transfusion. And just like any other allergic reaction, we treat them with antihistamines and steroids. In cases of anaphylactic reaction, which is similar than any other kind of anaphylactic reaction, that can include hypotension, angioedema, dyspnea, bronchospasm, laryngospasm. It begins rapidly in onset, like almost in seconds to minutes after starting the transfusion. And again, in these cases, we stop the transfusion immediately and manage it any other way we would manage an anaphylaxis. In cases of febrile transfusion reaction, which is non-hemolytic, normally the patient will develop spikes of fever after the transfusion has started, and generally there is a temperature elevation of 1 degree Celsius, or it can go even higher. The patient will complain of some rigors, some chills. If it is a first time transfusion and a febrile reaction occurs, then it should be treated like an acute hemolytic reaction, and obviously we stop the transfusion. And if the patient has a history of febrile non-hemolytic transfusion reaction, but no vital sign instability occurs, no symptom other than fever or chills, and the rise in temperature is generally less than 2 degrees Celsius, then we can continue the transfusion as normal. We can even use drugs like meperidine for prevention and treatment of rigors. If meperidine is not available in your hospital, then you can also use other opiates like fentanyl and hydromorphone. In acute hemolytic transfusion reaction, there seems to be an element of ABO incompatibility, and it is considered a very serious transfusion reaction. So obviously the recipient's serum has some preformed antibodies, and when the donor's RBC is received, the blood cells will start to hemolyze within seconds or minutes. These patients normally will again develop fever, chills, hypertension, shock. They may also complain of headache, nausea, vomiting, sensation of chest restriction, joint pain, low back pain. So whenever these symptoms develop, so we can see how presentation of febrile transfusion reaction and acute hemolytic transfusion reaction sometimes overlap, and they can become difficult to distinguish. That is why in both cases we stop the transfusion, we do some blood testing, and normally it is the blood testing that will tell us if it's a hemolytic or a non-hemolytic transfusion reaction. So in hemolytic, what are we expecting to? We will see that there will be a decrease in hemoglobin, we will see that there's an increase in LDH, increase in bilirubin, decrease in haptoglobin. Even if we send for the coagulation profile, we will see that there can be an evidence of DIC. So PT may be increased, PTT may be increased, fibrinogen can decrease, and if we have time to ever check their peripheral smears, then we will see schistocytes or spherocytes. Obviously, in cases of acute hemolytic transfusion reaction, the important thing is to use vasopressors or diuretics to maintain the urine output, and we stop the transfusion in the first place. The simplest way to confirm the diagnosis of acute hemolytic transfusion reaction, though, is detection of free hemoglobin in urine or a positive Coombs test. The next category is TRALI or transfusion related acute lung injury. TRALI is more associated with plasma and platelet transfusion, but nowadays we are seeing it with RBC transfusion as well. Because there is associated lung injury in these patients, they will present or develop the symptoms of a non-cardiogenic pulmonary edema with dyspnea, hypoxemia. If we do their chest x-ray, we will see bilateral infiltrates. If it's a more severe case, then we might even see fever and hypertension. Once again, if TRALI is suspected, stop the transfusion and notify the blood bank. Start them on respiratory support. Normally, non-invasive pressure ventilation works, but in severe cases, we might even have to intubate them and mechanically ventilate them. The final complication under acute category is TACO or transfusion associated circulatory overload. Generally, in these cases, the patient gets volume overloaded after transfusion, and they might have some risk factors for developing TACO, like they might already have congestive heart failure or some sort of renal insufficiency or the extremes of age. So again, it should be considered in patients who develop shortness of breath, hypertension, tachycardia, and other signs of volume overload once the transfusion is started. Once again, we stop the transfusion, we give them diuretics. If their respiration is affected, then we can start them on non-invasive ventilation. So, a summary of acute complications, except for mild allergic reaction which involves the skin, all other categories we stop the transfusion. Moving on to delayed transfusion reaction. So, a delayed hemolytic transfusion reaction can also occur, which normally occurs 3 to 10 days after receiving the blood. So they can present with fever, anemia, jaundice. Normally treatment is very supportive, and do remember to notify the blood bank in these cases. We also have a very rare but a fatal complication as part of a delayed complication of blood transfusion, that is transfusion associated graft versus host disease. Normally, the symptoms begins 3 to 30 days after the transfusion and includes fever, skin rash, diarrhea, elevated liver enzyme levels. The mortality in these cases is very high, almost at 95%, and treatment in these cases is normally palliative, but most of the times it is unsuccessful. The last category is post-transfusion purpura, which develops 1 to 3 weeks later, and it is associated with an antibody response to a platelet antigen. Normally, these patients are at risk of bleeding with, or they might present with active hemorrhage. Hence, they must be considered for high dose IVIG, plasmapheresis, or even platelet transfusion.